Tonight, a tale of two countries and two drug-buying agencies. One is ranked number 3 in the OECD in terms of access to medicines. The other, New Zealand's very own Pharmac, is ranked near the bottom, something that sparked intense pressure in recent times from patients with everything from cancer to rare disorders who say they're missing out and the system has to change. So how does the third-ranked country, the UK, run its agency, the National Institute for Health and Care Excellence, or NICE? For starters, NICE releases almost all of its assessment data, including board minutes. Pharmac does not. NICE approves more than 80% of the applications to fund new medicines. Pharmac approves fewer than a quarter. But perhaps the greatest difference is speed. While more than 100 medicines sit on Pharmac's waiting list, some for 5 years or even 10 years, NICE has no waiting list at all. The chief executive of NICE, Sir Andrew Dillon, is visiting New Zealand, and he sat down for his only interview here with Guyon Espiner. He told him that 3 months after a drug company applies for funding, NICE aims to make its decision.
For cancer treatments at the moment, our target is to send that signal out within 90 days of a drug receiving its licence. Whether we hit that target is a function of a number of variables, and it doesn't always happen. And we plan to extend that 90-day target to all kinds of drugs over the next couple of years or so.
So just to clarify that, because in New Zealand drugs can wait many years within the Pharmac system, you're saying that once a drug has been registered as safe and determined that it does work, you will give an assessment, a yes or a no, within 90 days, and then within another 90 days, it is potentially available.
That's the target currently for cancer treatments, to be extended to all treatments over the next couple of years.
We find within our system in Pharmac that the agency says, well, we're waiting for more evidence, and the particular drug might sit there for a number of years. That may allow more clinical data to appear, but there may also be a cost to patients who wanted to use the drug. What is your assessment about those costs and benefits, and why is it important in your view to have the timeliness?
So when we look at a new treatment, we're making a whole set of judgments, and to some extent we're also accepting a degree of risk associated with the things that we don't know about the treatment. Sometimes that risk is so great we simply can't support the use of whatever it might be. For cancer treatments, we've got a little way around that because we can access something called the Cancer Drugs Fund. And this is a special fund that's available when we're not certain about the potential benefits of a new cancer treatment, so we can't say, yes, let's go ahead and use it now, but that we can see real potential. And so what we can do is to agree with the company a price for a fixed period of time, perhaps 2 years or 3 years. We can agree a data collection package. We can agree the group of patients for whom the treatment should be made available. And then at the end of that 2 years or 3 year period, we can evaluate the new technology again and make a final decision on it. So it's a way round what otherwise might be a roadblock where we're just not certain. So the only option is to say no. With the Cancer Drugs Fund, we can say maybe.
So in simple language, this is a fund that allows drugs that are safe and they work to some degree, but there's not the level of clinical data to determine their long-term efficacy. You're allowed to dip into this fund in an experimental way with a greater level of obligation on the drug company to comply with your terms. Is that right?
That's right.
And is it working?
Well, so far, only 2 drugs have come out the other end, so it's a bit early to make any kind of sensible assessment of the overall impact.
And were they approved?
But those 2 drugs have been approved for routine clinical practice.
And that gives the United Kingdom far greater access to cancer drugs than we see in New Zealand, doesn't it?
Well, I don't know enough about the details of the arrangements in New Zealand. Obviously, I'm aware of Pharmac, I'm broadly aware of how Pharmac operates, but I've not done a detailed comparing contrast on the extent to which the current arrangements here enable access.
No, but drugs like Ebrance or Kadcyla are funded in the UK, aren't they?
Well, yes, and indeed there'll be drugs that are funded in other European countries, for example, that aren't funded or aren't immediately funded in the UK. So everywhere is different. Everywhere faces this challenge of wanting to maximise access to innovative new treatments to patients, by having to balance that against the funds that are available and the need to fairly access those funds across everything that we all expect our health systems to do for us.
For lung cancer, Keytruda, alectinib, osimertinib, crizotinib, all funded in the UK.
They are, yes, yeah.
Not funded here. We can't both be right, can we? You're either wasting money on drugs that don't provide enough benefit, or we're rationing drugs that work. We can't both be right, can we?
Yeah, but every country in the world is a bit different in terms of both the choices it makes and the ways it goes about making those choices. No two countries are really identical in that respect. And those choices are a function of the resources that are available, the priorities that the country has for its health system, the choices it makes on how to make funds available across different kinds of programs. And so it's inevitable that those differences are going to emerge.
Sure, but there must be a payoff in the medicines, otherwise you wouldn't be funding them.
Well, of course. And that's why it's so important to have a rigorous approach to evaluating the clinical benefits of those, as well as a tough but fair set of arrangements for working with companies to agree a price.
Well, let's talk about that, because you use an interesting formula, QALYs, quality adjusted life years. It's roughly £20,000-30,000. If it stacks up and you can offer me £20,000 or £30,000 worth of quality life, then you fund the drug, right?
Yes, yeah. Look, the quality adjusted life year is a way of bringing together the improvements in quality and length of life that a new treatment brings. It's not just for cancer treatments. You can use it for all sorts of treatments that the NHS makes available. And the benefit of it is that you can standardise the way you make decisions. So it works for cancer, it works for diabetes, it works for osteoarthritis, it works in mental health. And it enables you to ensure, firstly, that you're paying the right amount of money for the benefits the treatment is bringing. Secondly, that you're fairly allocating those resources so that you can be conscious that you're not advantaging a particular treatment or condition over something else.
So can you explain how that works? If a drug comes along and you think you are going to be able to provide the person with 3 quality life years for it, and it's going to cost £90,000, then the equation roughly stacks up, just to use a simple example.
Yes, if the treatment is, for most treatments, if it's falling somewhere below £20,000 to £30,000 per QALY, and by the way, that's a ratio, obviously. It's not actual pounds that we might spend. It's not the maximum we might ever pay for a particular treatment. It's an expression of its value for money. But for cancer treatments, we have the flexibility to go up to almost £50,000 per QALY. So
Why?
Because it's an indication of the priority that the NHS accords to access to new cancer treatments. It's an indication of the priority that cancer as a condition has within the health system. This is a choice, in effect, that the health system makes.
So you will spend up to £50,000 on 1 year of quality life for a person?
So up to £50,000 per quality adjusted life year, compared to a maximum of around £30,000 per quality adjusted life year for a non-cancer treatment.
To reflect the priority that you put on cancer.
Yeah, and this is not for all cancer treatments. This is only in specific circumstances where patients have a very short time left to live, and where the treatment itself has the ability to offer a significant extension to life.
And you say yes a lot, don't you?
Well, we like to say yes. If you look back over 20 years that we've been going, I guess we can find value in the new drugs that we look at in about 80% of the cases, 82% of the cases that we look at. It's a bit less for cancer treatments. It has historically been less for cancer treatments. But if you look overall, the great majority, 8 out of 10 of the things that we look at, we can say something positive about. So it's only a minority where either because the clinical data isn't strong enough or we can't establish a price with a company that makes the treatment cost effective where we have to say no.
You talked about transparency. That's pretty important to NICE, isn't it? You publish almost all the evidence that you've gained, holding almost nothing back.
No, we only don't publish something if we agree that it's commercially confidential. In some circumstances, that's appropriate in order to reach the point where we can agree with companies. But we work to minimise that. Our default position is that everything that we see should be seen by anybody else who's interested in what we do.
Does that extend to board minutes, for example?
Board minutes? Yes. If you're really, really interested, you can find out what goes on at NICE's board meetings by going to our website.
I understand you have public board meetings.
We do. We have 6 public board meetings a year. We have a road show that's been going on for 20 years around the country.
Is NICE reviewed?
I feel that we're constantly reviewed.
Formally?
Everything we do is subject to significant public scrutiny, which is appropriate. But yes, periodically the government will undertake a review of what we do, how we do it. Over the 20 years that we've been going, the government's had different approaches and different timetables for reviewing what NICE does. But I think the most recent review is about 5 years ago.
Which country would you rather be sick and need medicines in, New Zealand or the UK?
Oh, well, I'm very familiar with the NHS. I understand how the system works. I've grown up with it. Extraordinarily grateful to it for the support I've had from it and everything that my family's had. So inevitably and appropriately, my loyalties will be with the NHS in the UK.
Sir Andrew Dillon speaking to Guyon Espiner there, and he was brought to New Zealand as a guest of Medicines New Zealand, which represents drug companies, and he's also met with government ministers and representatives from Pharmac.